Thank you. Thank you for the invitation. It's really humbling to speak after these giants in endoscopy. I've learned so much this morning, so thank you for having me. I'm divided my talk into advanced adenomas, surveillance for advanced adenomas, as well as colorectal cancer. I'm just going to skip the first few slides in the interest of time. So before we talk about surveillance after resection of advanced adenomas, we must talk about the baseline colonoscopy, because all guidelines presume that an excellent high-quality baseline colonoscopy has been performed, at which point all important lesions have been removed. However, we know that important lesions can be missed at the baseline colonoscopy, and that up to 12% of larger adenomas greater than a centimeter and around 4% of cancers can be missed at this baseline colonoscopy. In an elegant study with 250 patients that were at increased risk of colorectal cancer, underwent CT colonography just prior to their colonoscopy, and only unexpected large false positive findings based on the CT colonography were verified by a second look colonoscopy. And actually 12% of the patients had polyps, large polyps. 8 patients with 8 large polyps, so 15% were overlooked by endoscopy and were only detected at the second look colonoscopy. The CT colonography wasn't perfect either. They actually had similar miss rates, but at least 15% of large polyps were missed on the first colonoscopy. We do a better job with left-sided lesions, as mentioned earlier, maybe because of poor right-side bowel preps, incomplete colonoscopies, and potentially different biology of right-sided polyps. So what's the definition of an advanced adenoma? As per our society guidelines, they basically are similar based on 3 features: size, histology, and the number of adenomas. Size being greater than a centimeter, everyone seems to agree. Histology, the British guidelines have separated them into intermediate risk and high risk being high-grade dysplasia and villus, and the number of adenomas, over 3 adenomas is accepted by most societies to have higher risk than less than 3. So let's look at each of these individually. So the number of polyps, which we don't tend to think of when we think of advanced adenomas, but the guidelines are all clearly looking at all 3 features. So for number of polyps, patients with 3 or more adenomas are definitely at an increased risk of more polyps on surveillance. And the National Cancer Institute pooling project, which actually took raw data from 8 prospective studies accumulating in over 9,000 patients, they defined advanced adenoma as greater than a centimeter, a polyp with high-grade dysplasia or villus features of greater than 25%, or number. And here the baseline, you see that the baseline adenoma number correlates linearly almost with the percent chance of having an advanced adenoma at follow-up. Also, the veteran study, another large study with over 3,000 patients, included patients who had normal colonoscopies, 500 of them, and over 1,000 patients who had polyps. They defined an advanced polyp the same way, except they included an invasive cancer, and they found that the risk of advanced neoplasia within 5 years also correlated strongly with the number of adenomas found at the first colonoscopy. So 2.5% risk of having an advanced adenoma if you had a normal colonoscopy 5 years prior, but a 12% risk if the patient had 3 or more tubular adenomas, all small, so just the number alone had a relative risk of greater than 5. All right, so what about size of polyps? Again, from the NCI pooling project, they compared diminutive polyps to polyps less than 2 centimeters and found that there was an increased odds of about 2.5, but when you compared diminutive polyps to polyps greater than 2 centimeters, the odds were about 3 of having an advanced adenoma or advanced neoplasia at the 5-year colonoscopy. Again, from the veteran study, comparing to a baseline of no polyps, so 2.5% risk in the no neoplasia group, whereas the risk if baseline adenoma was just greater than a centimeter was about 15%. Again, a relative risk of 5, so definitely an increased risk, but the studies don't agree exactly on the quantity of the risk. Now, what about histology? From the pooling project, they compared tubular adenomas to tubulovillus or villus adenomas. They lumped those together, and there was a slightly increased odds at 1.3 of having an advanced adenoma at follow-up. So not as dramatic as with number or size of polyps. What about high-grade dysplasia specifically? On univariate analysis, they found a 1.7 increased odds of having an advanced adenoma and follow-up. However, on multivariate analysis, they found that this risk was really accounted for by size and histology being villous, not the high-grade dysplasia in specific. So kind of different than what we would have expected. From the VA study, they found actually a pretty strong risk based on histology, where for a villous adenoma compared to no neoplasia, the relative risk was 6, and high-grade dysplasia just increased that to about 7. So again, high-grade dysplasia didn't make as much of an impact as the villous histology. From a retrospective study, 83 patients, but it was interesting. They found that 64% of patients with high-grade dysplasia developed an adenoma at some point within the 4-year follow-up. And initial high-grade adenoma greater than a centimeter was a very strong predictor. All right, so it's surveillance for the advanced adenoma, definitely based on size and number. Most of us for sure would consider villous adenomas and high-grade dysplasia to be a criteria for an advanced adenoma, even though the studies don't all agree. So these are the society guidelines. The U.S. Task Force recommends that the first colonoscopy for surveillance be at 3 years, and if an advanced adenoma is found at that time, then to continue at 3-year intervals. However, if a low risk or no adenoma is found, then to go to 5 years before returning back to normal screening. The British Society of Gastroenterologists as well as colorectal surgeons divide them into high and intermediate risk, as I had mentioned before, adding a colonoscopy at 1 year for the high risk, and otherwise then at 3 years twice before going back to normal surveillance. So what's actually happening? I found this study quite telling. Over 3,000 patients with low risk initially followed in a cancer screening trial. 25% of them with no adenomas at baseline had a repeat colonoscopy within 5 years, whereas 40% of patients with small adenomas or less than 3, so again low-risk patients, also had a colonoscopy within 5 years. However, 40% of patients with an advanced adenoma at their baseline colonoscopy did not have surveillance within 5 years, so we're not that good at following the guidelines. We had heard a bit of talk about incomplete and piecemeal excisions earlier, so we can decide about this on endoscopy and by pathology. The CARE study I thought was very interesting, and it was great to hear Dr. Pohl speak about it. So over 1,000 patients at which they took biopsies after the resection of the polyps, and as he mentioned, there was a 10% incomplete resection in this group of highly skilled endoscopists, and they found that size and histology were risk factors for an incomplete resection. And even though they were all highly trained endoscopists, there was still great variation between them. From a retrospective study of 830 patients with colorectal cancers, 45 developed an interval cancer, and 27%, again, as Dr. Pohl had mentioned in his talk, developed them at previous polypectomy segments. So although not all interval cancers are due to incomplete resection, at least a quarter of them are. So it's a significant problem. So what do our guidelines say? The U.S. Task Force in 2006 said to biopsy the scar, that the first interval colonoscopy, if a piecemeal excision or an incomplete resection occurred, should be at around 2 to 6 months, and to biopsy the scar, and I found that interesting, and I'm curious to know what others do. The new task force guidelines are a little more loose, saying within the first year based on clinical judgment, and they don't comment about biopsying the scar. The British guidelines in 2010 say to re-examine the site within 2 to 3 months, and if it endoscopically appears normal with no mention of biopsy, then to repeat every 3 years, and they recommend tattooing the area with India ink for further follow-up. So there's no real consensus on surveillance after piecemeal resection, or even what to do after the first surveillance colonoscopy, because we know that recurrence can occur long after a piecemeal excision. All right, what about surveillance after colorectal cancer? So there's even less clarity there. The 3 goals, I guess, of surveillance after colorectal resection for cancer is to detect early asymptomatic recurrences and hope to cure them, to detect metachronous cancers also at an early stage and hope to cure them. But more importantly than these 2 goals is to actually prevent any further second cancer or recurrent cancer and by removal of adenomatous polyps. So again, before we talk about surveillance, we really have to talk about preoperative clearance of the colon and rectum. An older study, but I think stresses the risk of synchronous lesions. 166 patients with colorectal cancer. 8 patients had synchronous cancers, that's about 5%, and just under 30% had benign polyps at the time of their cancer. Interestingly, most of the synchronous cancers and 2/3 of the polyps would not have been in the resection specimen had they not been identified preoperatively. So all guidelines agree that you have to clear the colon before we operate, and in non-obstructed colons, a full colonoscopy is part of our routine preoperative workup. In obstructed colons, it's important to get some form of imaging if possible to make sure that there isn't a second lesion that would have changed your management, and otherwise to do the clearance of the colon and rectum within 3 to 6 months after surgery. So with reference to the first goal to cure recurrences before they become unresectable, 480 patients who underwent a curative colorectal cancer resection had their colonoscopy within the first year after treatment. 10% had intraluminal recurrences, and I think because this is a bit older data right now, the intraluminal recurrence rate is probably 2 to 4%. But because they had the numbers, we can just see what the distribution of these are. Over 50% of them occurred within the first 24 months, and only 60% of them were resectable, and only 46% of them were asymptomatic. So the recurrence period is within the first 2 years, and about only half of those patients that present with recurrence will be resectable. So we're looking for small numbers. So if the recurrence rate is about 2 to 4% for colon and up to 10% for rectum, we're hoping to catch half of those while they're asymptomatic, and about only half of those can be cured. The risk of intraluminal recurrence is within the first 2 years. So what about metachronous cancers, and how do you exactly define metachronous cancer? It's definitely a second primary, not at the surgical resection site, but how do you know it's not a missed cancer? Essentially, we don't. As long as the preoperative screening was performed, anything else in the postoperative follow-up will be termed metachronous. Busy slide of multiple studies trying to just detail what the real risk of metachronous lesions are in patients who've had a curative colorectal cancer resection, and we could just pay attention to the totals at the bottom. Again, we're looking to catch something that's quite rare at about 1.5% of patients. 42% of these metachronous lesions occurred within the first 2 years. Half were pretty early stage, as stage 1 or stage 2, and 45% were reoperated on for cure. So similar to the older data I just showed you. An actuarial analysis with competing risk analysis looked at this in 500 patients with a median follow-up of 5 years, and they also described about a 3% metachronous cancer rate at a median interval of 90 months, which is a little longer than I would have expected. And they concluded that age under 65 years old had a 2% 5-year risk of a metachronous cancer, whereas older patients had less than a 2% 10-year risk, and that our guidelines should take this into consideration. All right, what about removal of metachronous polyps? So they're all retrospective studies, but overall rate of metachronous polyp detection in patients who've had a colorectal cancer is quite high, ranging between 17 to 50%, definitely higher than the general population or in patients who've only had an adenoma and haven't had an adenocarcinoma. At our institution, we looked at the rate of metachronous polyps at the first surveillance colonoscopy, so in 181 patients, and our median time to first colonoscopy is about 1.1 years in concordance with the guidelines. We found that the overall adenoma detection rate on the first colonoscopy was 30%. And of the ones captured in the first year, 60% were advanced adenomas. So what do our societies say about candidates for surveillance colonoscopy? We don't all agree. Some societies say that all patients that are medically fit who still have curable disease, including stage 4 colorectal cancer, as long as they're considered curable, should undergo surveillance colonoscopy in the postoperative follow-up, whereas some societies, including the Cancer Care Ontario from Canada, as well as the European Society, deem only stage 2 and 3 to have enough data to support surveillance colonoscopy, being that stage 1 has a very low recurrence and that surveillance in stage 4 will not render to cure. However, as we look at some of the data, you'll see that data is clouded for all stages. What's the surveillance that's recommended? This has changed in the last 10 years, and more societies are agreeing to a first colonoscopy at year 1. And depending on the findings of the colonoscopy at year 1, most agree that the following colonoscopy should be at 3 years, and if that's normal, then at 5. Perhaps we're over-surveying based on the data that's available. What about surveillance for rectal cancer? We know that the local recurrence for rectal cancer is much higher. However, the local recurrence for rectal cancer is not usually intraluminal. It's usually a mesorectal recurrence, and so there's not much evidence at all for flexible sigmoidoscopy. However, most of us are adamant, and we do flexible sigmoidoscopy every 3 to 6 months for the first 2 years, and every 6 months to complete 5 years, and the societal guidelines are along those recommendations. So surveillance colonoscopy for colorectal cancer really has to be considered within the context of colorectal cancer surveillance in general, which is a history and physical, CEA levels, imaging. And the earlier randomized controlled trials compared minimal follow-up to intensive surveillance, and every study has their own definition of what is minimal follow-up and what is intensive surveillance. However, what they all agree upon is that there's very low rates of metachronous cancer and recurrence rates, and these randomized controlled trials all had small sample sizes, and there was no survival benefit to intensive surveillance. A more recent randomized controlled trial included 300 patients, an intensive group, which was quite intensive, receiving colonoscopy at 3-month intervals for the first year and 6-month intervals in the next 2 years, and a routine group, which is still a little more intensive colonoscopy than some places do. And they did find that it improved overall 5-year survival by a very small amount, from 77% to 73%. However, they were detecting asymptomatic cancers and were able to have longer disease-free survival. After that, multiple meta-analyses of randomized controlled trials. Problem is that all these randomized controlled trials are still small because we're looking at a very small event. And these randomized controlled trials, when pooled, demonstrated an overall decrease in mortality at 5 years with intensive programs, intensive being a very different definition for every study. So a lot of these, as I said, they vary in their definitions. This led up to the Gilda Trial, which is a great effort by our Italian colleagues, 41 centers in Europe, and they enrolled stage 2 and stage 3 patients with colorectal cancer that were cured, and their primary objective was to look at 5-year overall survival and health-related quality of life in this cohort. They randomized over 12,000 patients equally to both arms of minimal and intensive surveillance. And they had a minimal and intensive surveillance pattern for colon as well as for rectum. And in terms of colonoscopy, minimal surveillance meant a colonoscopy at 4 months and at 4 years, and intensive meant annual colonoscopy for 5 years. In addition, rectal cancer patients in the minimal protocol were offered proctoscopy at 4 months and proctoscopy at 4 and 8 months, in addition to the annual colonoscopies for the intensive program. More than 90% of their patients actually followed all the expected diagnostic procedures, which is a great feat, and their median follow-up was over 5 years. They had 250 patients with recurrence, which is an expected proportion, and they did not find any difference in overall survival in both groups, and health-related quality of life was the same in both groups. Cost effectiveness of surveillance, again, it really depends what surveillance is going to be. This one study from Europe looked at colonoscopy, CT chest, abdomen, and pelvis, CEA on an annual basis for stage 1 and 2 colon cancer, as well as physical exam, sigmoidoscopy, imaging, and CEA for stage 3 and 4 colorectal cancer. And they found that the annual mix of physical exam, colonoscopy, imaging, and CEA was actually cost-effective for stage 1 and 2 colon cancer. What's the impact of the patient when you have intensive surveillance? So patients have multiple exams, anticipating results, as was mentioned earlier. And in an elegant study from England, They found that patients had no problem and were actually reassured by this testing and visits to the physician. And even if it wouldn't lead to earlier detection of recurrence, they found that this was reassuring. So I'm not sure how much what we do really is supported by the data out there. What's nice is that the guidelines are all converging. The problem with this question is that there's very low rates of intraluminal recurrence, and surveillance colonoscopy alone for the purpose of detecting recurrence has no established survival benefit. Doesn't mean we're not going to do it. Surveillance colonoscopy within an intensive program perhaps can increase curative resection, but its impact on survival is really not clear. The primary goal in my mind for surveillance colonoscopy is really to prevent future cancers by detecting adenomas and resecting them. Surveillance is likely reassuring to the patient, and hopefully, if done in a conscious manner, can be cost effective. Thank you.